Test 1, 2, 3.
Test 1. Test 1.
Microphone check. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Microphone check.
Red button. Hit the talk button when you want to talk.
Subcommittee will come to order. Good afternoon, everyone. Nice to know that you've got a high tolerance for snow days. Pretty impressive all the way around. Before we begin, I'd like to echo the observation and express our shared sorrow that Chairman Brady did this morning in the full committee hearing, and offer our condolences to the passing, to the family of our colleague, Louise Slaughter. She faithfully represented her New York constituents for more than 30 years and was quite a force on the Rules Committee. Many of us testified before that committee, and she was no one to underestimate. Let's get started with this hearing. For those who've been around for a little while, it wasn't too long ago that we were still living by an all too familiar deadline in healthcare, the annual and sometimes annual headache and complete hassle that was known at the doc fix. There was nobody that was happy about this. There was nobody that was satisfied with this, and it was just universally loathed. The sustainable growth rate, or SGR, was a failing payment model that was supposed to control costs in Medicare, but in turn created payment uncertainty for doctors in Medicare that Congress acted to avert 17 times over the course of 15 years. 2 years ago, this committee came together in a bipartisan fashion, working with stakeholders and CMS to craft the Medicare Access and Chip Reauthorization, or Macra, because we didn't have enough acronyms, by consolidating the separate reporting requirements and rewarding higher quality care. We've begun to move toward a system that fully integrates value-based care and places the proper incentives on high-quality care. That's not to say that the law is perfect. And while in its intent, the success of Macra lines up with the success of the Medicare program and the move to value over volume, today we'll hear from the Centers for Medicare and Medicaid Services, or CMS, on how the implementation of that intent is going and whether or not we've learned lessons from the past 2 years as it relates to Macra. Several technical fixes to Macra were included in the Bipartisan Budget Act that we passed in February. These changes grant greater flexibility and discretion to CMS as they continue to implement this new program to ensure that there's no unattainable goals that will prevent our doctors from succeeding if what they're doing is the right thing, and to avoid any cliffs that will create a loss of faith in this blossoming new payment program. We also included a fix that would expand the responsiveness of the Physician Technical Advisory Committee to stakeholders that have submitted ideas for alternative payment methods. APMs are foundationary to the intent of Macra, that providers work together to create new, more efficient payment models that would result in better outcomes for patients. So I hope that the PTACs, CMS, and the Innovation Center and all are working together to maximize the amount of models available to our doctors in Medicare. And we're holding this hearing as a continuation of our commitment to oversee proper implementation. That's the scope of this hearing, to discuss the implementation of Macra and to understand its role in the move to higher value, more patient-centered care for our seniors. So I hope that on a bipartisan basis, we're going to explore these issues. Our role as Congress is to provide oversight and, in conjunction with CMS, continue to provide education on a law that's working, how it's working for providers in Medicare. And as we explored at the last Macra hearing, the question is CMS continuing to make sure that our small and individual practice providers have the opportunity to succeed under this program. We hope to continue to hear from stakeholders as we move forward beyond this hearing and to work with CMS in implementing this law correctly. And I think we can do some good work. With that, I'll now yield to the ranking member for the purposes of his opening statement. Mr. Levin.
Thank you very much, Mr. Chairman. And all of us on this side join you in remembering Louise Slaughter. Anybody who had the privilege, if you want to call it that, of appearing before the Rules Committee noted her tenacity and her patience laced with impatience. And she was a determined battler, and her sudden passing has left us all poor. Thank you, Mr. Chairman, for holding this hearing, and thank you, Mr. Kazoukas and Dr. Goodrich, for joining us. Nearly 3 years ago, President Obama signed into law Macra, the Medicare Access and Chip Reauthorization Act. This bipartisan legislation put an end to the recurring threat of draconian Medicare cuts under the flawed sustainable growth rate formula. By creating a new quality payment program and alternative payment models that reward physicians and other providers that coordinate care and achieve better outcomes, Macra took us several steps forward in our effort to make Medicare an increasingly value-based program. I just want to add to my remarks how this was an important part of ACA as we worked on it, to really move away from fee-for-service to a value-based program. So we look forward to the hearing today to see what progress has been made. However, as useful as today's meeting is in reviewing Macra, we must recognize that we are not holding this hearing in a vacuum. The actions of the Republican majority and this administration have caused upheaval in the healthcare system that has undermined many of the goals we hope to achieve through Macra. Regrettably, throughout all of this chaos, this subcommittee has not been sufficiently active, holding just 3 hearings prior to today. The President has consistently worked to undermine and sabotage key aspects of ACA through administrative actions. These include ending cost-sharing reduction subsidies, slashing funding for navigator groups in the area I come from, slashed by 90%, and outreach programs, and most recently expanding the reach of short-term policies that can evade important patient protections. These and other actions have left the insurance markets in chaos or near chaos and resulted in major premium increases in many parts of the country. Yet despite the urging of us Ways and Means Democrats, we have not held any hearings on any of these issues. As we move forward, we must no longer ignore these harmful proposals. Furthermore, we must acknowledge that the President's budget would devastate access to care for millions of Americans. His budget cuts more than $1.4 trillion from Medicaid by switching to per capita caps and block grants while ending ACA's Medicaid expansion. It also slashes $532 billion from Medicare through, among other cuts, a radical restructuring of the graduate medical education program and devastating cuts to home health agencies and nursing facilities that serve the most vulnerable beneficiaries. When it comes to value-based payment, the approach of the administration has not reflected the bipartisan, I emphasize that, commitment that Congress showed in passing Macra. Instead, it is more about conservative ideology than common sense innovation. By massively scaling back value-based payment efforts begun during the Obama administration and hinting at a shift towards premium support and privatization experiments, the administration has left many seniors worried about what lies ahead for Medicare. Mr. Chairman, Macra was a truly bipartisan effort, and we've shared a goal of ensuring that it is ultimately a success. Today's hearing reflects that bipartisan commitment. However, we must not ignore the broader developments that have undermined this spirit and threatened to greatly overshadow the improvements made by Macra. Thank you, Mr. Chairman.
Thank you. I'm pleased to introduce today's witnesses, as we're fortunate to have them both have got a broad background and know what they're talking about. Demetrius Kazoukas from Chicagoland, I might say, originally. He's a Principal Deputy Administrator at the Centers for Medicare and Medicaid Services and the Director of the Center for Medicare. And he's joined at the table by Dr. Kate Goodrich, the Chief Medical Officer at CMS and also the Director for the Center for Clinical Standards and Quality. We're really pleased you're here. Mr. Kazoukas, why don't you tell us what you know? You got 5 minutes, and then we can inquire. Thank you.
Thank you, Mr. Chairman. Chairman Roscom, Ranking Member Levin, and members of the subcommittee. Thank you very much for the invitation and the opportunity to come here today and discuss the work we are doing at CMS, the Centers for Medicare and Medicaid Services, to catalyze a transformation in our healthcare system, from one that pays for sickness and procedures to one that pays for value and health. When I talk about our work in this regard, people ask me sometimes, what does value mean? After all, it's an ambiguous term. And I want to tell you today that value means putting patients in the driver's seat, ensuring that patients are in a position to make their own determinations about the care they receive in consultation with their providers and with the support of their families and communities. We know that many problems in our healthcare system come from the fact that it has been assembled in Washington rather than assembled by patients. And so what I'd like to talk to you about today is the course we've charted to how to remedy those concerns and challenges. Secretary Azar has outlined 4 areas of emphasis that we undertake in this fundamental reorientation of our healthcare system. First, give consumers greater control over their health information through interoperable and accessible healthcare information technology, their medical records. Allow them to get their information in their hands so that they can move around and be consumers in a healthcare market. Second, encourage transparency from payers and providers so that patients can make choices based on price and quality as they would in any other market. Third, leverage the power of patients and put resources behind them by using the authorities at CMMI and otherwise in Medicare and Medicaid to help drive value and quality through the entire system. Last, reduce government burdens that impede this transformation by ensuring that patients can spend more time talking to their physicians and facing them in one-on-one conversations rather than looking at the back of their lab coat. These are the same principles that guide our implementation of Congress's vision for Medicare clinician payment through Macra. As Principal Deputy Administrator and Director of the Center for Medicare, I lead a dedicated team. It's a real privilege to work with so many civil servants who have worked hard to achieve this vision in many different forms. I'm pleased in particular to be joined today by CMS's Chief Medical Officer and Director of the Center for Clinical Standards and Quality, Dr. Kate Goodrich. Kate has been on the front lines of our hard work to drive value and quality and remove government burdens that impede the transformation I discussed. In thinking back about this conversation, this dialogue we're going to have with the committee today, I started to think in particular about my first interactions with the healthcare system, at least the ones that I can remember. And I thought back to the times where my sister and I helped take care of my father. My father suffered through a number of chronic diseases through much of his adult life, and we spent many times, working with him and other providers as a whole family as he went from doctor to doctor and hospital to hospital to provide that support in our own family for someone who was sick and wanted to get healthier. And I have to say that in those experiences, those encounters, I always wondered, why is it so confusing? Why don't these doctors talk to each other? Why is it so hard to get copies of these medical records? Why can't we ensure that we have an opportunity to make decisions about the care that's right for us rather than have the feeling that so much is being done to us? These experiences fueled my interest and passion in healthcare, and they shaped the perspective that I bring to CMS and the important work that we're doing. As I got more opportunity to participate in healthcare policymaking, I saw that too often the problem is that we have created a healthcare system that has erected fractured silos over the care that providers give and the opportunity that patients have to drive their choices. Providers are driven largely by empathy, a desire to help the people standing in front of them who aren't healthy and who need help. And we've made it more difficult for them to channel that empathy towards helping that whole patient. The work that we're doing is about transforming that, about giving providers an opportunity to put themselves at the disposal of their patients and work with them, support them as they experience a transformational shift to patient-driven healthcare. And Macra is part of that. We're implementing Macra in a way that's consistent with that general philosophy. Last year, this administration focused our attention on making Macra work in particular for individual clinicians, as well as small and rural practice groups. We provided additional flexibility to small groups, increased the threshold for participation in one aspect of Macra, and made it easier for clinicians to join together in what are called virtual groups. We're grateful for Congress's continued leadership in this area, particularly the additional flexibilities that were granted in the recently enacted Bipartisan Budget Act. We're working every day to ensure that healthcare decisions are made by patients, in consultation with their healthcare providers and with the support of their families and communities. CMS will continue to drive towards this vision of what value-based healthcare means. In so doing, I am certain we will achieve the vision of a healthcare system that is not assembled in Washington, but assembled by each patient.
Thank you, Mr. Kazookas. I'll now recognize Mr. Johnson to inquire.
Thank you, Mr. Chairman. Mr. Kazookas, welcome. Back in 2015, then President Obama signed legislation which I championed with Representative Doggett to end the use of all Social Security numbers on Medicare cards as part of the Medicare Access and CHIP Reauthorization Act. Ending the use of Social Security numbers on these cards is vitally important to protect our seniors and other Medicare beneficiaries from identity theft, as well as to prevent fraud and abuse. Now, it's my understanding Medicare will issue new cards next month and replace all cards by April 2019. Mr. Kazookas, is that still true? Just yes or no?
Yes.
Thank you. Is CMS still on track? Yes or no?
Yes.
And can you tell me how Medicare is getting the word out to seniors about the new Medicare cards?
Thank you, Mr. Johnson. First of all, let me thank you for your leadership on this issue, not only in ensuring that the legislation was passed to protect seniors, but also in providing the resources that were necessary for CMS to implement this important initiative.
Thank you.
We've been grateful for the opportunity to interact with seniors and prepare them for this transition. After all, identity theft is an issue of concern to everyone in today's world, and these new steps will put us in a better position to help Medicare beneficiaries not be put in a vulnerable situation. We're working very diligently to ensure that we roll this out on the timeframe that Congress envisioned, and in particular, one of the things we're most sensitive to is the right timing of that message. What we've found is that seniors are very concerned about their privacy. They're very concerned about how they access the Medicare program. And so it's particularly important as we engage with them that we give them information at the time that's most helpful and useful to them about what's coming, and that we work with them as they have questions, and that we also work diligently on the provider side so that they're in a position to help answer questions or experience changes in the system. And so the steps that we're taking largely involve a lot of planning and internal deliberation over exactly how to communicate when and what and how, with a careful sensitivity towards the needs of this population. It's not like communicating with other kinds of people that are in a general marketplace for consumers, let's say, for example. It's a particular population that has a great desire and a focus on these messages. And we're also very diligently involved in making sure that the behind-the-scenes experience works when people are presenting with the new information and the new cards, and that there's a facile transition, if you will, from one system to the next.
Well, do you think you're on track to get it done expeditiously in a year, I guess?
Yes.
That's a positive answer. Listen, I thank you for doing what you're doing, and I hope you can get the word out to all the seniors about the new Medicare cards, and I thank you, and I yield back.
Thank you. Mr. Levin.
Again, welcome. I'm going to resist the temptation to talk again, as I did in my opening statement, about what this administration is doing to undercut Medicare and Medicaid. Also, to resist temptation to talk about the legislation that I and others introduced relating to dental, visual, and hearing. I instead want to focus in on the whole issue of value-based that you talk about, because as I look about, those of us who were very much involved in ACA talked a lot about value-based, and we undertook efforts in ACA to move away from fee-for-service to value-based. That was somewhat, if not the origin, the placement of emphasis on ACOs, on medical homes, and on the Center for Innovation. And so I must confess, after you talk about the importance of getting better value for our investment, you then go on to say to make sure that patients are in the driver's seat, making their own determinations about the value and quality of the care they receive. I mean, that's the rhetoric that we always hear, and to some extent, I mean, we agree with it. To have patients more involved, to put them in the driver's seat essentially is used often as rhetoric to move everybody else out of the driver's seat. So I just want to talk to you about what you've been doing. Apparently, CMS took steps relating to one of the experiments of the center relating to hips and knees. We talked a lot about the need to try to bundle, to put together procedures, and to put together the providers that related to those procedures. So you've taken steps essentially to undermine that experiment, to cut the number of sites, to make it voluntary. So tell me how you defend undermining or taking those steps that were put into ACA or into the instrumentality that led to this effort to try to address that procedure in a way that was value-based. How do you defend making it voluntary, reducing the number of sites?
Thank you very much for the question. And I do
I'm not
think
sure
that,
you want to thank me, but go ahead.
well, I do, because I think we share the goal here of ensuring that patients have access to healthcare in a way that makes sense for them. And the way that we've thought about this, just to give you a bit of an analogy, is that when you go out to buy a computer, you're buying one brand or another, you're buying an entire computer. You're not buying 14 different parts of a computer and assembling it yourself. And I think that's important, not only for the reasons that you mentioned, but also it's very consistent with the philosophy that I laid out of patient-driven healthcare.
Okay, I understand that, but how do you defend the steps that you've taken to erode that experiment? How do you defend it?
I think what we've seen, and the diversity and breadth of the committees and membership here today reflects it, is that healthcare in this country really varies quite a bit across the entire nation. That a lot of regions have different arrangements, different cultures, different kinds of markets that have emerged. And what we're trying to do is ensure that as we embark on this journey together and work with the committee and others to get to that common shared goal, that we do it in a way that reflects and builds upon the experiences of each community, and that we provide as many variations and options to people as possible so that as we get there, we do it in a way that makes sense for each community.
Mr. Buchanan.
Thank you, Mr. Chairman. I appreciate the opportunity for both of you to be here today. Let me ask you, in our area, as you can imagine, we have a lot of seniors. I talk to a lot of different patients and some doctors. Everybody's a little bit concerned about cyber attacks. And I guess there's been some threats in the past and some reality. This as we move forward with the systems that we're talking about. Where are we at, or what is CMS doing about, preventing that? And then I guess I would add, is there any incentives for docs to make sure that we're doing as much as we can? And I'd like to hear from both of you on that issue.
Great, I'll start, and then Kate will have something to add. One of the most important things we're doing is the work that Mr. Johnson asked us about, which is that we're working hard to ensure that Medicare beneficiaries are identified by a different number than their Social Security number, what we call the HICN, or Healthcare Identification Card number. And this number, as you know, is largely overlaps with the Social Security number, and that presents an opportunity for, if there is a cyber breach of some kind, for bad people to take advantage of not only the government and individuals. And so we're working hard to ensure that that new system is rolled out in a way that makes sense and protects the integrity of the system and for seniors. We also obviously take a great deal of care with regards to the security and privacy of the information that we have. It's an incredible resource. And it's really interesting, if you ever have an opportunity to visit our headquarters in Baltimore, when you drive up to the front gate, the security is really unlike any other federal building, or most federal buildings that I have the opportunity to visit. And it's quite intense. And I think sometimes when we have visitors come and meet with us there, they remark upon it. And I explain to them that while the work we do is really important, and we obviously take care to safeguard our headquarters, the reason that there's so much intense focus on the security is because we also have a lot of private information there. And so it's really integral to what we do every day in all of our systems, all of our operations, all of our IT contracts, all of our vendors. We have woven cybersecurity and information security generally into our practice because we've had to. We sit on a treasure trove of information. I'll ask Kate to supplement that with anything she might have to.
Yes, thanks. Very important question, and something, as Demetrios says, we take very, very seriously within the agency. So I can speak to what we are doing as it relates to what we ask of our provider community, and in particular for hospitals who participate in the EHR incentive program, also known as the Meaningful Use program, and for clinicians who are participating as part of the quality payment program. These providers are, through these programs, using certified EHR technology, and there are a number of things that we require of those providers as part of that program, one of which is that they conduct every year a security risk analysis of their EHRs. This is a critical component of the program. In fact, we're thinking about ways that we can further strengthen the emphasis on security and privacy as a part of that program.
Okay, just as we move forward, my concern is with all these registries and data information sharing. My sense is we've made a lot of progress in the last couple of years. Is that your thought as we move forward in this area?
Yes, sir. When we work with the registry community as part of these programs, we have certain parameters and requirements that they have to meet in order to be sort of CMS qualified, if you will, to participate in these programs. And some of those requirements are indeed around security and privacy of patient information.
With that, I yield back.
Thank you. Mr. Thompson.
Thank you, Mr. Chairman. Thank you both for being here. Mr. Kazoukas, I want to thank you in advance for something that my district experienced just a horrific fire this last year. We lost 7,000 homes. People were displaced, and sadly, healthcare really took it on the chin. And my clinic folks have been working with HHS to figure out how collaboratively to put the pieces back together. And you've been very helpful, I understand. And I just want to let you know that they think they're still going to be having trouble, and they're going to be calling on you for more help. And that would be greatly appreciated. So thank you very much. And earlier this month, the administrator, Verma, announced that the My Health eData initiative would be focused on improving patients' access to their own health records. And that was good to hear. However, we've been hearing that for about the last 10 years. And I want to know what we can expect will be different now than has been the practice over the last decade. Is there something that you can tell us that will convince us that, in fact, something's being done differently to force interoperability? And why is it that when it's not working, the doctors are the ones who are penalized rather than the providers?
Thank you. And it's been a real privilege to work with you and others to help communities that have been affected by disasters recover. And that it really, I think, goes to show how important healthcare is to people's lives. It's such a fundamental piece of the social fabric. And that when a natural disaster strikes, one of the first things that we're worried about, obviously, is how are people who are sick or otherwise vulnerable going to get access to the care they need, and making sure that that infrastructure stays in place. So it's been a privilege to work with you and the rest of the team at CMS on that. As to your question about interoperability, I think that the particular focus we've got is unique, and it's unique because of its focus on the patient. And I'll say that interoperability is obviously important. Any kind of efficient system is going to need to have pieces that work with each other and talk to each other. But our focus in particular is not on interoperability for its own sake, but interoperability because of the opportunity that it presents for patients to be empowered, to have that access to their information. And so in that regard, this is distinct and this is different. And that focus will allow us to drive further, we believe, and deeper and more significantly to achieve an impact that's meaningful. We also think that the work that we're doing to reduce burden and to ensure that the government's needs in terms of collection of information and documentation and all the other kinds of hoops that we have the healthcare system jump through, that relieving that is going to allow us to focus providers' energies on the kinds of changes that they might need in order to achieve this vision. So we're really excited about that work, and we'll be looking forward to implementing it in the decisions that we have an opportunity to make in the coming time. And then we also obviously welcome your input and that of the committee in how we can best achieve that vision, because you've had the opportunity to see it evolve as well.
Thank you. I'd also like to know what you can tell us that we can expect will be coming about in regard to implementation of telehealth. That's one of the areas where we can do a heck of a lot of good in underserved areas, and we really need to roll that out to the best of our ability and to the maximum extent possible. And then lastly, I'd just like to raise the issue of cuts to, budget cuts to some of these programs that are so important. You know, if you take over $1.5 billion from safety net hospitals, $48 billion from the health workforce programs, and money from Medicaid, you really are undermining the whole system, and it can't be made up by providing opportunities for individuals to better shop for health care or even things such as rolling out the a better telehealth program.
Thank you. So with regards to telehealth, we couldn't agree more that this is an important initiative, not just for rural areas, especially for rural areas, because of the issues that are related to access.
Underserved areas in general.
Indeed. And we also feel like it's an important part of healthcare in the 21st century, that we can't engage with the healthcare community in a way that doesn't recognize that technology in the world has changed. There are some fundamental limits in terms of what Congress has imposed for how we deliver healthcare services in telehealth settings, but we are looking very hard at what we can do within our existing authorities. I can also tell you that ultimately there is always this challenge of cost in the system with regards to your other question and resources. And ultimately, we think that if we put patients in a position to help drive that value, we're going to get to that better place, partly with the vision that Macra had in mind.
Thank you. Mr. Smith.
Thank you, Mr. Chairman, and thank you, Mr. Kazoukas and Dr. Goodrich, for being here today and sharing your insight and expertise. I represent a rural Nebraska district where physicians face unique challenges in the delivery of health care. I would say the most common grievance I hear from rural providers is the amount of administrative burdens imposed on them by the government, certainly due to limited resources that they have in carrying out their duties. As you know, it takes time away from caring for patients, and I appreciate the time and attention CMS is giving to reducing physician burdens in this way. On November 2nd of last year, CMS published its 2018 Quality Program Payment Final Rule for the implementation of Macra. A Can you outline some of the features of this rule that continue to provide flexibility for physicians to report their data, particularly those in small individual or rural practices?
Yes. And I've got to tell you that this notion of burden, it isn't just a sort of a abstract idea that there's too much paperwork and process. It's very real, and I think I see it every time I go to visit a healthcare professional or a doctor. And I think that it's something that, in fact, I've experienced personally a bit of a change in how I interact with doctors when I go to see them in their offices, that I am spending less time with them, and they do seem to be buried into their devices, if you will. And I understand that that's part of the challenge here. So we're really working really hard to address that in a lot of other ways. With regards to your particular question about the Macra program and the regulations that we issued last year, I think put our money where our mouth is, if you will, sort of action speaking, I think loudly, that in fact, we do recognize the challenges that small rural providers have, and we made two particularly important adjustments. One is that we raised the threshold, what's called the low volume threshold. That's the threshold, that's the minimum sort of size or scope of a practice that you needed to have, if you will, before you're subject to the requirements and impositions and the opportunities, perhaps, that Macra offers. And we increased that in order to recognize that we wanted to meet physicians and their practices where they are. We wanted to allow for that variation of community, and that in different communities they're in different places along sort of the value spectrum. We also made changes to allow for virtual groups. And virtual groups are an opportunity for physicians to join with others who aren't in their practice necessarily, but who they'd like to be measured with as part of a larger group, if you will. And those have been important accommodations. We are really excited about the changes they portend, and we're continuing to focus on this. And I'll ask Kate to talk a little bit more about the reporting aspect.
Absolutely. So as Demetrius says, this has been a critical issue for this program. We've heard many of the same things. I'm a practicing physician. I know firsthand what some of those administrative burdens are, and they are particularly acute for clinicians in underserved areas and rural areas and small practices. So in addition to what Demetrius highlighted, we also provided a hardship exception for the advancing care information or health IT category of MIPS for small practices who were unable to procure an EHR. And then finally, we want to thank Congress for providing resources under Macra for technical assistance that is very specifically directed at clinicians in independent and small practices in underserved areas and rural areas. We awarded these contracts now over a year ago, and since that time, they have been working directly with these providers to help them understand the program, to help them be able to meet the requirements of the program, and ultimately to be successful.
Thank you. I yield back.
Ms. Sewell.
Thank you, Mr. Chairman, and thank you both for being here today. As we examine the implementation of Macra, we must acknowledge that first, our healthcare system is supported by payments from Medicare and Medicaid. So the President's proposal to cut Medicare by $500 billion would send shockwaves through the entire healthcare system. And secondly, our reliance on emergent care is one of the largest drivers of long-term healthcare costs. There is a wide consensus that removing barriers to primary care is essential to restraining the growth of healthcare spending. As we discussed our transition to a value-based payment system, one of the barriers I'd like to discuss is transportation. But first, I'd just like a yes or no answer, Deputy Administrator. Can you give this committee assurances that rural hospitals and rural providers will not be adversely affected by this administration's cut in Medicare?
We've been working every day to ensure that the programs that we undertake and the way that we implement them recognize the unique needs of rural providers. And so I assure you it's very much at the forefront of our minds, and we've made adjustments and will continue to do that.
Well, I just want you to know that just like my colleague from Nebraska, I have a disproportionate amount of folks in my district that live in rural areas, remote rural areas actually. And I can't tell you how many hospital closings I've gone to in the 8 years that I've been a member of Congress. And it's really unacceptable. My constituents shouldn't be left behind just because our governor didn't expand Medicaid and we didn't get more money. I think that we have to look for creative ways to make sure that we have access. Everyone has access to quality, affordable health care. And so with that in mind, I'd like to talk a little bit about one of the biggest barriers, which is transportation. So often, many of my constituents can't make primary care appointments, and because of the long distance, and they don't have anyone to help, get them there. And so it's costing a lot of money for us to actually, their dependency on ambulant care, by taking ambulances for emergency care. And clearly that's a cost driver. And I would think that we would save lots and lots of money if we could figure out ways that we can help people make their appointments. There's lots of innovation when it comes to transportation. I know that in many urban areas, Uber is like getting reimbursed by hospitals in order for folks to make their appointments. Clearly, it's more constrained in rural areas, but I would love to talk to you, love your thoughts on what we can do for non-emergency transportation needs when we come to Medicare.
I couldn't share your concern more. And if you think about it just from a human perspective, the situation of someone who they have access to this wonderful resource that the Medicare program has made available in terms of the scope and the number and variety of providers to access the care. They have an appointment, perhaps, that's, a provider that's ready and willing to take them and help them through their healthcare situation. And the sort of the tragedy, if you will, of someone not being able to get there, but for lack of
it's a huge cost.
That last mile. Yes.
Yeah, I think that it's said that our health system loses $150 billion each year for missed primary care appointments. And I can tell you, I have lots of constituents that call me. Sometimes they call our office to see if there's any way that we can help come get them to take them to primary care appointments. It's unacceptable in this great country that we call America that people who have access to health care, who actually can, because of their situation, Medicare and Medicaid, they actually have a card that will allow them to get health care, but they can't actually access it because of transportation barriers. Do you see any way that we could have more innovative type of strategies to really deal with the very real barrier of transportation? Absolutely. And I think that, first of all, I'd like to make us available to work with you on that. I think it's an area where there is an opportunity. And the opportunity starts with understanding how we got here, which is a bit of this sort of Byzantine and fractured system that we have as a result of this sort of slow evolution and the rules that have sort of grown up around it. There are some really bright spots, though, I think, in the area of transportation. Medicare Advantage plans, for example, can offer transportation benefits. I worked on that. Thank you. We also had some recent guidance or regulation that was issued by the Inspector General's office that sort of opened up some of the rules and limitations around transportation. We also are obviously focused on really new and innovative models that might include transportation, but also might include care in the home. Well, I'd love to work with you on non-emergency transportation costs for Medicare. Thanks. Thank you for the opportunity.
Ms. Jenkins.
Thank you, Mr. Chairman, and thank you both for being with us today. Mr. Kazoukas, as we approach the first data submission period for Macra, I join my colleagues in looking forward to reviewing the data and using it to help inform efforts to ensure the program is effective and meets the goals of enabling clinicians to deliver the highest quality and most efficient care. I'd like to applaud CMS for their leadership, for some of the important steps it's taken to ensure this program is carried out successfully. Macra has required tremendous investment, coordination, and education on the part of hospitals and clinicians. I personally continue to hear from hospitals in Kansas that CMS's gradual approach to implementing the program and expanding Macra's requirements has been critical to their ability to successfully integrate the program into their delivery systems. I appreciate CMS's focus on regulatory relief in implementing Macra. For example, CMS has allowed hospital-based physicians to use their hospital's value-based purchasing performance in the MIPS, beginning with 2019 reporting. For many clinicians and hospitals, this means more time improving care and less time reporting data. Additionally, I commend CMS for factoring into the MIPS a complex patient bonus that accounts for the severity of illness and the number of dual eligible patients and practices. This helps ensure reimbursement better aligns with the level of care a patient's provided. One of the most important aspects of the Macra are the incentives for clinicians to participate in leading-edge alternative payment methods. These methods give providers a bonus for participating in models where they take on significant risk for managing the cost and quality of care for specific treatment episodes or across a population. When looking at alternative payment models, I would like to emphasize that in light of the millions of dollars of investment which have been made by clinicians and hospitals to implement, it's critical that there be opportunity for those in one-sided risk models to benefit from the payment incentives in the advanced APM model track. Could you share your perspectives on this?
Of course. And I think that it really takes us to that higher level and all-encompassing point that in approaching how we implement Macra, we can't have a one-size-fits-all solution. And what we're doing in terms of how we implement it is that we're looking for opportunities to offer as many variables, options, and choices for physicians to participate in a way that makes sense for them. We recognize, of course, that participating in APMs is going to involve some level of effort and ultimately risk. And MIPS offers as well sort of a building block, if you will, for how physicians can get there. And it's interesting to think about the two programs in tandem, that we all share this. I think implicit within Macra is a promise and a hope that APMs are going to offer this ultimate destination of a patient-driven model, a value-based model that's defined by patients. How do we get there? Given that each physician community, each healthcare community has sort of its own needs, we get there by, in part, for many physicians, it's going to be through the MIPS program. And if you look at what the MIPS program is comprised of and compare it to, say, a managed care contract, you see that it has a lot of the same elements. It's got some level of risk, and that's not just risk for its own sake. That's risk that essentially, it's defined as risk, but it's ultimately about capital. It puts resources at the hands of the physician so that they can invest in that patient and support them through these kinds of ultimate transformative decisions. It's got reporting, and in particular, in order to enable that reporting, electronic medical records and the like, and it's got measures, and that's all about focusing on the patient. So I hope that that gets to the point of explaining how we support so many different kinds of communities in making this transformation, whether it be through MIPS or APMs and all the different flavors of APMs that might come with.
Okay, thank you, Mr. Chairman. I yield back.
Ms. Chu.
Mr. Kazoukas, I applaud the transition from fee-for-service to systems that would be more efficient, cost-effective, and value-based. And that's why I'm so glad to see the development of the next generation accountable care organizations, or ACOs. One of the ACOs is the all-inclusive population-based payment model. And the model gives the ACO a set payment each month to cover the expected costs of providing care to Medicare beneficiaries. I just happen to have the first ACO that signed up for this in my district, and they were very excited to do it because they believed they could provide significant savings to the Medicare system while providing quality service. However, they ran into an issue with secondary payer crossover claims or billing error when a beneficiary had a secondary payer like Medicaid, and the providers were submitting their claims to CMS, but a missing step in the coding process had the unintended effect of double paying providers for treating beneficiaries with secondary insurance. Well, thankfully, we were able to work this out with CMS, so I appreciate that. However, I'm concerned that within the rollout of these new models, we will see more of these unintended errors as we try to reform the Medicare system. So, Mr. Kazoukas, could you discuss the steps CMS is taking to ensure that payment errors like the one that occurred in my district do not happen in the future?
Yes, of course. And I will say that just in approaching the question, that a part of the environment that we're operating in is one where we've got a very complex healthcare system with a lot of imperfections in its own right, as it existed pre-Macra. So I just want to make sure that we think about the new vision in comparison to the status quo, which has so many challenges in and of itself, and has so many pieces of the puzzle that don't all fit together in quite the right ways. And so there's risk even in not making change, I would say. And I think that gets to my next point, which is at some level, not only at some level, really fundamentally, the programs and the models and the demonstration projects that you're talking about and that we've been working on, they are experiments at some level. They are new startups. And it's not something that the government has historically been very nimble and capable of pulling off in terms of iteration and constant change, but that is the task you've assigned us with Macra and the opportunity you've given us to help improve people's lives. And so I think that the answer to your question is that we will continue to be diligent, we will continue to get stakeholder feedback, we will continue to be open to concerns when we roll something out, we will, in advance of rolling it out, work as much as possible to get input about how things actually work, and we're going to work to engage in solutions that aren't manufactured here in Washington, but that we know have some precedent, some practice, perhaps, or an opportunity for improvement in the real world.
Thank you for that. I'm anxious to ask another question on a different subject, which is, I'm a clinical psychologist, so by background, so I have a great interest in how mental health services are delivered in the Medicare system. Right now, the Medicare beneficiary population is growing 3 times faster than the number of psychologists providing services. When surveyed, the psychologists have said that the #1 reason they don't participate in the program is declining reimbursement rates. In the last 10 years, reimbursement rates for psychotherapy services have dropped an average of 17%, and rates for psychological and neuropsychological testing services dropped an average of 23%. So, Mr. Kazoukas, what is CMS doing to increase rather than decrease the number of mental health providers like psychologists in the Medicare system at a time when the demand among beneficiaries is only increasing due to conditions like Alzheimer's and dementia? And let me also say that the American Psychological Association is eager to meet with you to begin the dialogue on this, and I'm hoping that that can take place.
Oh, first of all, we'd love to have the meeting. Look forward to the conversation. And I think that I just want to ring in with my endorsement of the importance of the question, not only obviously for the care of so many people who suffer from mental diseases or other have the need for mental health care services, but also and behavioral health services, but also because of the opioids crisis. And that we believe that this is a key part of addressing how the affliction that opioids has wrought on our communities. I can say that we've done something very specific that gets right to the point that you're making, which is inside the physician fee schedule, the system, as you know, for how we pay physicians in Medicare. We made changes last year to recognize that there is an important aspect of practices that don't have a lot of capital-intensive needs, who basically operate with a desk and a chair and an office, essentially. Obviously, they don't have big, expensive machinery or diagnostic equipment in their offices to adjust their reimbursement. And we set that out in the physician fee schedule last year. I look forward to hearing about the improvement that it's hopefully made to address the very issues you raised, and look forward to discussing with you or others how we can do more.
Mr. Marchant.
Thank you, Mr. Chairman. Mr. Kazoukas, I have visited with some of the doctors in my district just recently and have heard from several of their physician organizations. Their big complaint is they say that the Stark laws are creating real barriers to their coordination, and they're necessary to get them to succeed in participating in some of the new programs, some of the new value-based programs. 24 different physician organizations representing 500,000 doctors have endorsed some legislation that I am an original co-sponsor of, the Medicare Care Coordination Improvement Act, because they cannot participate in APMs under the current law. Can you speak for a moment about what CMS is doing to alleviate the stark burden, and can I get a commitment from you and to help serve these physicians and patients by working with me and the committee to help advance this legislation?
Yes, we'd be delighted for any opportunity to work with you. The particular legislation that you're referring to, I haven't had the opportunity to study, but I can tell you that about a few exciting things that we're thinking about and working on in this area that I hope address your concerns in part as well. First of all, I think that the discussion of Stark as part of the entire dialogue and conversation we're having today is really important. It's an obscure law, perhaps, to those who don't have to deal with it, named after, obviously, Representative Stark, but it has a really big impact on how relationships are structured in the healthcare space. And our focus on it is essentially a recognition that when we're talking about value-based care and ensuring that the value-based healthcare has that patient-driven focus, and that we're talking about creating a healthcare system that's not assembled in Washington but assembled by each patient, you have to look at all the arrangements that are arrayed behind the physician that's facing the patient and the complex web of financial and other relationships that come about, partly as a result of the evolution of the healthcare system, to have so many fractured silos, to have so many rules and regulations that govern every part of the healthcare system. And what we acknowledge that Macra is just a piece of this, that we've got to look at the other parts, and Stark is an important piece of that. And I think that you'll also see in the President's budget an important recognition of this with respect to the Stark Law. We do have a proposal in there that sounds similar to the concept you've described, and we look forward to continuing the dialogue.
This is H.R. 4206. The author is Representative Bouchon, and a lot of co-sponsors. I think all of us share in that. So I would like for you to review this, please, and present it to the chairman for a possible consideration in a later meeting. Thank you.
Mr. Kind.
Thank you, Mr. Chairman, and thank you for holding this oversight hearing. And I would respectfully recommend that we have a lot more oversight hearings such as this, just so we get some feedback on healthcare reform and learn what's working and what isn't working, and find some bipartisan paths to move forward. And I'm glad my good friend, Mr. Marchant, just drew to your attention the bipartisan bill that we've introduced in this committee, and they've have a comparable one in ENC, to address some of the problems we have with Stark and the anti-kickback provisions and the effect it has on our independent physicians in our districts and throughout the country. So I'm glad to hear that you recognize that there's a problem that needs to be fixed, and we look forward to working with you and the administration in order to find a path forward in order to address it. Another problem that obviously existed within the healthcare system is the so-called sustainable growth rate, the SGR, the cliff that we faced every year, the box that we were in with calling for huge draconian cuts to physician reimbursement payments. That created a lot of angst and a lot of concern about that taking effect. And every year at the last minute, we came through with a pile of money to prevent it. That, in part, was the reason why we needed this Macra fix in order to move forward, but also to continue to drive the system to more value, to outcome, to performance-based incentives. And that, I think, holds some promise. If we can align the financial incentives the right way within the healthcare system, telling our providers, you know, you're going to be rewarded for doing good things, not just by doing more, but by getting good results, good value, good quality at the end of the day, that's going to create a lot of innovation, a lot of change that we need to see throughout the healthcare system. And in that light, the previous administration had a goal of over 50% of all Medicare payments being value or outcome based by the end of 2018. Is the current administration still on that track of hitting 50% by 2018? And if not, why not?
Our goal is to ensure that the healthcare system that we have an opportunity and a privilege to create an influence for for patients in the Medicare program is the one that's right for each patient. And we think that APMs and value-based is an important part of that. And frankly, we think that there is really a big opportunity. It's hard to put a number on the size and the scope of the opportunity here in terms of where we think we can go and how bold we can be. I think ultimately the check will be how ready people are for it and the timetable for it. And I think that the success is going to be measured by people's willingness and ability to come to where we put the windows and the doors for them to enter.
I appreciate hearing that from you. Obviously, you're not going to change the way you pay for 1/5 of the entire U.S. economy overnight, but I just encourage you, don't let up too much on the gas as far as moving for value and quality and outcome-based payments. We need to keep that pressure on. Otherwise, status quo is going to be the enemy of the reform that we need to drive this system. And we know within Medicare where the major cost drivers are. It's not the per capita spending per patient, which has been relatively flat the last 8 years since the Affordable Care Act was passed. Previous 10 years, we were looking at 7-8% inflationary increases every year. And since then, it's been relatively flat. The real cost drivers now is the fact that we've got 70 million boomers who are rapidly approaching retirement age, 10,000 a day joining the Medicare system, and the cost of prescription drugs. We ought to be having more hearings in Congress as far as bipartisan answers to the drug cost problem we have as permeating the entire healthcare system. Do you, the administration, have a list of proposals that you're willing to share with us today on how we can best address the cost factor with prescription drugs that patients rely on and need in the healthcare system?
Thank you. And let me address each part of the question. First of all, with respect to letting up on the gas, I don't think you, like to assure you, no worry about that, because I think that when we give patients a taste of the opportunity to be empowered for their own health care, when it's not that little kid I was, helping my parents navigate the system, but it's instead someone who feels like they can make a choice and it matters if they go here or they go there. We're going to have to
glad to hear your commitment to that. What about the prescription drug problem and the price?
So we can move quickly to get out of their way as they get there. In terms of the prescription drug problem, and particularly in this context, I wanted to perhaps call your attention to the scope and breadth of the comment solicitation we made in fall of last year, in a document that we called the New Directions Request for Information. And it set out the administrators and the secretary's vision for bringing us into a new direction. A lot of the concepts we've talked about today, and drug pricing was a critical piece of that. We laid out a couple of things that gave people enough of a flavor for the kinds of things we want to accomplish on a bipartisan basis. And we've received over 1,000 responses to the RFI generally. And we're confident and looking forward to working with you on solutions.
Hope to see more details in the future. Thank you.
Mr. Paulson.
Thank you, Mr. Chair. Mr. Kazookas, good to see you here, along with Dr. Goodrich. The annual doc fixes under the SGR formula and the way that doctors were paid for procedures and sickness is way behind us now, and we do need a full transformation toward value-based healthcare that drives that greater accountability and improved outcomes and quality and lower costs. And that said, Macra and the alternative payment models and other federal-based program accountability, which is the downside or the upside risk, it falls mostly on physicians and hospitals. But physicians, of course, don't treat patients in a vacuum. They order their tests, they prescribe medicine, they rely on electronic data, and they work with other physicians to achieve better patient outcomes and reduce cost. Mr. Kazookas, maybe, or Dr. Goodrich, you can comment also, what is CMS considering in terms of opening up opportunities for all stakeholders across the healthcare sector, various different stakeholders, to innovate, to collaborate in value-based arrangements, both within and outside the context of Macra alternative payment methods?
Thank you. I'll start, and then Kate can jump in and add some here. We're really excited about the dynamic of that you're bringing to the table here about competition and bringing in new players. We really strongly believe that the system is going to work best if there's an array of choices, and those choices might well come from the existing structures. But I think the Secretary has laid out in some of his speeches, a willingness to be disruptive, and a willingness to change the rules of the game in a way that are going to invite new forces into the healthcare system. And I think you've also seen this in the New Directions RFI that I just mentioned and that the administrator put out last year. The breadth and the scope of the creativity and innovation that's envisioned in that document, I think indicates a complete agreement with you that we need to be open to new players, we need to be open to innovative solutions. And just to highlight some of the areas I think that are indicative of that, we specifically sought comment in that RFI on consumer-directed care, market-based innovation models, on physician specialty models, on prescription drug models, as I just mentioned, on Medicare Advantage innovation models, on state-based and local innovation models with respect to Medicaid, on mental and behavioral health models, and on program integrity. And I think that with each of those, we didn't just list them. We talked about how and why this fit into this vision of a patient-driven, value-based healthcare system and the opportunities that exist to make changes that are going to be disruptive, that are going to bring about those new changes. And it won't be just for its own sake. That sort of flexibility, that innovation, that disruption is also very much consistent with making sure that there's a solution for each community. Because every community, every patient, they're going to have their own needs, their own flavors. And the more we can do to ensure that the system that Medicare beneficiaries face and have an opportunity to take advantage of has as many different ways of interacting with them, of supporting them as they make those decisions, I think the more successful we're going to be, and the more you're going to look back at the work you did in Macra and be really proud about the new direction it brought us to.
And Dr. Goodrich, maybe before you comment, just so I can get one other question real quick, you can both comment. You know, we have a lot of Minnesota medical device companies, others that want to be those stakeholders and be incentivized. One other important aspect of Macra is the merit-based incentive payment system option for what are called eligible professionals to report more data, possibly receive a reimbursement bonus similar to APMs. What steps is CMS taking also to include specialty-specific measures, including those specific to like physical therapists, for instance, or other rehabilitation providers within MIPS for the 2019 reporting year?
So thank you for that question. I think that's a really important point you're making, that we've certainly heard from the clinical community that there aren't always the right measures or enough measures for particular types of specialists. So one of the things that Macra did was provided resources for us to work with specialty societies and other types of stakeholders to develop the right kind of measures, more outcome-based measures that are relevant for specialists. We recently, in the last, I think, 2 weeks or so, released a funding opportunity announcement for use of those funds under Macra to work with specialists and with patients to develop measures in these areas. And you mentioned physical therapists and rehabilitation specialists. Physical therapists and occupational therapists have long been enthusiastic participants of some of the legacy programs as well. The Macra legislation allows us to include those types of clinicians in the MIPS program beginning in the 3rd year of the program. So we are in the process now of developing our proposed regulation for the 3rd year of the program. And so we'll be making some proposals and suggestions around those types of clinicians as well in that regulation.
Good. Thank you. Yield back.
Mr. Blumenauer.
Thank you, Mr. Jack. Welcome. I appreciate the thrust of your testimony. I must say, you know, 3 years ago, Macra was a step to end the charade that we're all tired of, putting off the theoretical cuts that we didn't want and fought aggressively to prevent. But the fix was based upon the notion that there were actually cost savings that we could better capture to be able to deal with the intent of the SGR, however flawed that it was. Implementation would be a challenge, I think, under the best of circumstances. But I'm more than a little troubled that we're looking at contrasting what you're talking about here in sort of encouraging tones, but we're looking at a budget from the administration that is $1/3 of $1 trillion cut in Medicare over time. Medicaid is in the crosshairs. Efforts to undermine the work to pay value over volume, like the bundled payments for hips and cardiac care. and canceling some of the proposals to lower costs or making participation voluntary instead of mandatory. So it appears that the administration, on one hand, is working against some of the very goals that you have here. And I know Mr. Levin has referenced that, and I think we all ought to be troubled by the schizophrenia on the part of the administration, by putting things attempting to put things in motion that would undermine everything we're talking about here. But I would like to focus instead on an area that I think we ought to be able to work on. I think you are fully capable of helping us implement. I've spent a lot of time working on end-of-life care, kind of the death panel guy that we had here some years ago on committee with actually bipartisan effort to make sure that families' wishes and needs at that critical phase were taken care of. And we've made some progress. Slower than I would like, but I think we have made some progress. We have sent to the Secretary and the Administrator a letter that was from Senator Isaacson, Senator Warner, Representative Phil Rowe, who's been my partner here on the House side on these efforts. We believe that the CMS already has authority to develop patient-centered advanced illness management models to support individuals with serious advanced illness. We also believe, as set forth in the letter, that better metrics are necessary to ensure we provide appropriate and high quality of palliative and end-of-life care needs for these people with advanced illness that honors and aligns with their goals, values, and informed preferences. The work we've been doing on a bipartisan basis is to instead to actually help families know, respect those needs, and make sure that that expression of need is honored regardless of the circumstances, because in end of life, sometimes people are traveling or circumstances are difficult to operate under. We believe that CMS should consider strategies under the beneficiary engagement and incentive model to develop decision support tools that would empower patients and families to ensure that providers and caretakers are fully informed at every stage of their illness. Now, I've been encouraged by some of the words we've heard from the Secretary and the Administrator. We really would appreciate your reviewing the correspondence and working with us to see if there aren't things that we can do that I'm convinced would end up actually reducing financial burdens, but most important, giving people the care they want, deserve, and expect in some of the most difficult circumstances they will face. So I commend the letter to you, Mr. Chairman. I'd ask unanimous consent to enter it into the record.
Without objection, so ordered.
And look forward to any reactions, advice, and counsel you have with the work we're doing both in this Congress for other legislative tools and making sure that you have the resources to implement this little slice, but something that could have an outsized impact on America's families. Thank you for your consideration.
So, Mr. Kazoukas, the hang time on that question was really elegant, and it's right sort of at the end of Mr. Blumenauer's time. So let me just invite you to kind of quickly wind it up, and then, with your permission, I'll inquire at the end of our time, but
I'm
please
sorry,
respond.
Mr. Chair, I didn't mean to.
No, listen, you're a pro. Please respond.
Thank you. And it really brings home to me, I think, a really important point, which is patient-driven care is going to mean a lot of different things for where people are in their in their life and their care experience. And with Medicare beneficiaries, given the population, obviously we're talking about people who ultimately are facing that sort of difficult circumstances at the end of their lives, inevitably. And the support of how we can work as the Medicare program to support families in those situations. I couldn't think of a more noble and empathetic thing to do. It's, obviously the greatest pain we have sometimes in our lives is going through those experiences, and the opportunity to work with you and others to help people through that is a real privilege.
Thank you very much. Thank you for your courtesy, Mr. Chairman.
Mr. Reed.
I apologize for the
Not at all.
Thank you, Mr. Chairman, and I'm going to echo what Mr. Blumenauer just said, just to follow up on his questioning. I support the efforts of making sure that we deal with end-of-life care, that we have that conversation, especially as people go into Medicare. See it as a great opportunity to have that discussion about what their wishes will be, and it also generates a lot of savings at the end of the day, given that we spend in the last 6 months of our lives our biggest healthcare dollars. I also want to start by thanking you, Mr. Kazoukas. We've talked before on issues dealing with diabetes. I'm a father of a type 1 diabetic, co-chair of the Diabetes Caucus. Thank you for your work with Omnipod and other issues that got that taken care of and you addressed and helped millions of Americans get a better outcome and a better care working with that issue through your office. That all being said, I just want to kind of back this off a little bit. You know, we got some material here and we're getting prepared to go over the issue of going to this value-based reimbursement model. I totally support it and appreciate it. And I can just think of the people back home and the people I represent in Western New York hearing the conversation we're having here today. And we're talking about a patient-driven system that we're trying to get to that will force competitive market pressure into the healthcare arena to get better outcomes, better value. And I have a list, to the chairman's point, you know, and this is how sometimes we talk to our constituents. You know, we got this new Macra that's coming through HHS, and CMS is the one running it, and you got to talk to the ASPE, who will give you some advice as to what the volume-based is going to be based upon, and then you got to talk to CMMI, and I got 60-year-olds, 65-year-olds going, what the hell are you talking about, Tom? And so from my perspective to you, let's have a little exchange here. When you say you want to have patient-driven outcome value type of process brought into the Medicare system, tell me how to talk to that 65-year-old to say, this is what we're doing. This is how you can participate in the program now. With this new model that you're used to and all those acronyms, translate that to 65-year-old who's going, I have no idea what the heck they're talking about. Tell me how to give him or her information to say, this is how you can change healthcare system deliveries for you and your colleagues, your peers.
Thank you, and it was a real privilege to work with you on the diabetes issue that you referred to, by the way. The work of the committee was, I think, quite substantial and helpful to us as we worked to find a way to a solution that recognize the needs of individual patients and recognize as well that we are now clearly into the 21st century. Amen. And innovation is a part of the healthcare transformation that we're all trying to achieve.
So talk to me about, tell me what to say to a 65-year-old that when they interact with Medicare, this is what we're trying to get to, and this is what you need to do and to drive this better outcome and this better mechanism through Medicare.
I'll tell you a little bit about how I try to explain what I'm doing to my own mother, frankly.
There you go.
Because it's a bit of a challenge. I think she thinks I move a lot of paper around sometimes. But
how do you talk to her?
And I want to tell her about how happy I am to have the opportunity to work on things that are going to make a difference in her life. And what I talk about is what she taught me about being a shopper when I was growing up. She was the one who made sure that we got the best prices, and if that meant going to 3 different stores and for the grocery list, and this store for one thing and another store for a different thing, that's how she pulled it off. And I've talked to her about what I'm trying to do is, and along with all of the colleagues and Kate and so many other good civil servants who are working with us, is that we're trying to give her that opportunity too. That when it comes to the doctor that she goes to, when she falls and hurts her knee on a Saturday afternoon, that she isn't just going to the first name out of the phone book, and she isn't.
What do you envision for her to be looking into? That's what we have to. That's what we have to send to the American people. They don't get it. I'm just telling you. Your mom. That's a great conversation. I appreciate that. But they don't get it. They're like, I don't see that. I don't see that happening. What are you trying to tell them we're getting to?
Well, sometimes I talk about other complex decisions that she might make in her life, like choosing an auto insurance policy or a car insurance or a house insurance. Obviously, this is far different. This is about your own personal health, so I don't mean to say that it's the same. But I say, well, when we sit down and figure out what the right car insurance, what the right auto insurance.
What information are you looking for tell your mom to give to your doctor? What are you telling your mom to be able to make sure to give other people the opportunity to get that transparency?
I want to make sure that she knows that she's got confidence and comfort in the person she's going to be dealing with, and that she's not forced to just go to the sort of the random person who's there, and that she feels like she's got a choice. If she doesn't like the experience and she doesn't think she's getting good care, then she's working with someone who's going to give her the right things that fit for her.
And if I just, in closing, I just want to be honest with you. That's not getting to the people back home. It is not being delivered. They have no idea what you're trying to do. And when you talk in the language you talk here, they don't get it. And all they say is, it's a bureaucracy, it's driven by the bureaucracy, and there's nothing I can do about it. So we have to do a better job of getting through that.
I think our challenge has been that there's so much structural work that needs to be changed that by the time it sort of translates into an action that they see, we're going to get there. But we're working on pieces that are so far behind the scenes right now. Sorry.
Ms. Black.
Thank you, Mr. Chairman. I guess I'll wrap this up, or maybe you'll do the final wrap-up. Oh, Mr. Kelly's to my right. I apologize, Mr. Kelly. I'm taking up my time. So, first of all, thank you, Mr. Kazoukas, for being here, and Dr. Goodrich. We appreciate you because this is quite a complicated situation, as my colleague has already represented. And as a nurse for over 40 years, implementing common sense policies that help promote patient-centered care like VBID are at the top of my list, and I hope a priority here in Congress as well. With over 50% of my district in Middle Tennessee being rural, and I know we've already spoken a little bit about that, these small, rural, and independent physician practices and physician-led groups are well positioned to lead the transition to value-based care and succeed in new payment models, and I know they want to do that. And while those large institutional players continue to dominate many of the CMS current value-based care models, physicians and physician-led alternative payment models have untapped potential to improve the outcomes and reduce the cost. So along with addressing the burden of the MIPS on those small and independent practices, what is CMS doing to make it more feasible for physician practices and physician-led groups of all sizes to take the downside risk and to move into the advanced alternative payment models?
Thank you for the question, and delighted to also hear within it a nod to the work we've done within MIPS to ensure that that program enables practitioners and physicians to be successful in making this transition. As we look at APMs themselves as a sort of another category here, I think the bottom line answer is that we are working to create more APMs, and I think the new directions RFI that the administrator put out in the fall really highlighted the breadth and scope of how broadly we're thinking about that. And I think the more APMs we have, the more variations there will be for physicians to find the one that's right for them, and that will have its own success. The other thing I think that's really important is that as we consider what those APMs look like, we can't adopt a one-size-fits-all approach. We've got to really acknowledge that the need to meet people where they are and that there are these regional variations. And then I wouldn't stop there. I'll say that in 2019, the new all-payer combination APM is coming in. And the real opportunity there, I know we're throwing around a lot of acronyms, obviously, but what that does, as you know, is that it creates an opportunity for physicians to count their participation in private plan APMs as well as Medicaid managed care and Medicare Advantage APMs towards the threshold amounts that qualify for APM status and the APM bonus. And so that's also going to, I think, provide an opportunity for the practices that you're talking about to really participate. And we haven't stopped there. As you may have noticed, in last year's rulemaking, we also indicated that we're working on a demonstration project that we that work is still underway. A really exciting demonstration project that would create an opportunity for physicians to count towards their APM participation measure the Medicare Advantage panel size that they've got and the number of patients that they have or revenue derived from Medicare Advantage in a two-sided risk arrangement. And all of those things, I mention all of them and I go on a little bit at length just to give you a flavor a bit of the breadth and scope we're looking at for how to make this fit right for each physician practice. And we're not doing it necessarily just for them because we know that behind every physician there stands an entire group of patients who are counting on that physician to be successful and help them navigate this system that we're working towards.
Well, thank you for that. And I want to also mention, I know I don't have much time left, I really am interested in knowing what will be done on innovative benefit designs, such as reducing or eliminating the cost sharing for beneficiaries or creating a preferred relationships with their specialists, because I know in rural areas that is very important to them, that they would be able to participate in such programs as well.
I think that those are the kinds of things that we specifically sought some comment on in our New Directions RFI, and we've gotten over 1,000 responses. We're continuing to work through them, and we're really excited about the opportunities that we have that we've seen in those responses, as well as dialogue with others regarding new models and new ways of thinking about the way that patients and physicians can interact, and our role in the Medicare program.
Very good. Thank you. I yield back, Mr. Chairman.
Mr. Kelly, bring us home.
I think we are home. No, we're not. Mr. Chairman, thank you. Dr. Goodrich and Mr. Pizzuc, thanks for being here today. One of the things that I think all of us we're trying to get to is how do we run a system that gets better by paying for value, right? And last week, Mr. Kind and I launched a new bipartisan healthcare innovation caucus, and we see that the United States has the highest cost of care per person in the world. We need to think critically about how we can control costs while improving quality for Americans. And I don't think it's too far of a stretch of the imagination that innovation is truly in the DNA of the USA. So, and I don't think healthcare should be any different. One of the things I keep wondering about, there seems to be such a disconnect between what we do in medicine and what we do in other business models that work in our society every day. And I'm an automobile dealer, so almost everything we do in our business is based on different guidelines that are out there. And for somebody who's a prospective car buyer, they can look at a number of different sites or pick up a number of different publications that tell them what they should be paying for a particular automobile based on how it's equipped. We also have the same thing when it comes to doing repair work. There's something called labor time guides, Chilton time guides. They are based on time studies, and it will tell you exactly what these different operations should be taking, how much time it should be taking to do it. Now, the key to being in that business, by the way, is that you can operate under the time guide. So if it says it's going to take 1.6 hours to do it, and you can do it in 1.2 hours, you still get paid 1.6 hours, with the caveat that if the work isn't done right, you do the rework on it for nothing. So I'm wondering, just how close can we ever get in this sector, in the public sector, into actually taking a look at how things work in the private sector and how we can control costs by getting better at what we do and spending more time actually on the job as opposed to inputting data continuously that takes away from our time, in this case, with patients, in this case, with wellness programs. And I'll go back to something, I think when it comes to healthcare, there's a different conversation, but relating to the car business, do you remember an ad that was for Fram? It was a guy that held an oil filter. It was a mechanic, and he said, you can either pay me now or pay me later, and he was tearing apart somebody's car. I think what we're looking at too often in healthcare is we're paying later for things that weren't taken care of earlier. And I'm talking now about wellness programs, I'm talking about nutritional programs, I'm talking about how we would get there. So is there any other thing you can discuss on any type of an alternative payment program or method that would help out with this situation? I know you're working on it very hard. This is 1/5 of our economy right now. I don't see it slowing down anywhere soon. It's going to get bigger. Medicare chewing up quite a bit of what it is that we spend in Medicaid. How do we get to the point where our providers can spend more time with patients and patients can spend more time with their providers as we look at how we work on the data that's being submitted?
Thank you. First, let me thank you for your leadership in establishing the Innovation Caucus. We're looking forward to learning more about your work, and I'm sure the productive energies of the members who are working with you. And I say that not just because you brought it up, but because we fundamentally believe that innovation is a key part of this transformation. And in fact, I think at times one of the wonderful things about our healthcare system is that we have brought so many innovative medical technologies forward. And in many ways, I think it's been in spite of rather than because of the way that our system works at times. in terms of the reimbursement side. And that's why we're very focused on innovation as a key part of this transformation. And if you start to sort of unpack that as just, instead of just innovation as a broad-minded goal, you think about what brings about innovation. And this is sort of the process we've engaged in thinking about how we're going to get there. And innovation comes from people being willing to take risks and develop new ways to help people through their healthcare crises. And how do they do that? Well, they're going to need resources. How are they going to figure out exactly whether or not something works? They're going to need to go out and they're going to need to test it. They're going to need to get through all kinds of experience in the marketplace as well as the regulatory situation. And that means that they need to go to investors. And investors are going to provide them with capital. And what do investors want to know? They want to know what the ultimate reimbursement system is going to look like. They're asking those questions. And so the more we can do to create predictability around that, so that investors can put their resources into things that help people fight cancer and other afflictions, rather than, and I love, social media and all the new technology, but I'd rather have American investors putting money into helping people cure cancer than necessarily another sort of way to do social media. I can't even keep up with the ones that kids use now. So we're very focused on that, and the way and what we're doing in terms of how that translates into action is that if we lay out these patient-driven goals, if we design a system that ultimately empowers patients to make decisions about where they get their care, then the market will evolve to feed those patients' needs and to address them. And ultimately, the investors will line up behind that as well, and that'll continue to create a very beneficial cycle, we believe, where we've got the capital going into the right place to help the right kinds of new innovation that are going to help providers meet the needs of patients, and at the end, everyone benefits.
Well, I want to thank you for what you're doing. I know when the chairman first started out to become chairman of this health subcommittee, he said, what we're going to attempt to do and what we're striving to do is to make sure we're delivering health care to people in an effective and efficient way that leads into their senior years where they're healthier and they'll be more effective. They'll be able to live a better life. And I think we're all trying to get to that same point. So I appreciate what we're doing. I know it's very difficult, but I really appreciate what we're doing. We're going to continue to work with you every step of the way to make sure that our providers and our patients see the full effect of they get a return on that investment that America is making. So thanks so much. Mr. Chairman, thank you. I yield back.
Thank you. So thank you for your testimony today, Mr. Kazoukas and Dr. Goodrich. It's been insightful for us, and I think in terms of our goals and notes in the areas that we wanted to cover, members either ask those questions themselves, or you raise those questions on you raise those issues on your own, and so that was really helpful. Let me make one point and then ask sort of a blue sky question. So I feel like the proctor. Okay, pencils down, and so here's this one quick point. So I represent suburban Chicago that you grew up in, Mr. Kaczynski, and we ended up having a discussion with one of the local hospitals who was recently surveyed by CMS, and one of those formats with the Illinois Department of Public Health, or somebody comes through with a clipboard and the whole thing, and they said, oh, you've got a problem in this hospital. And they said, well, what's the problem? Well, the problem is your HVAC system is 18 inches too close. You've got a shaft that's too close to something. So it's just ridiculous, obtuse. This hospital's meeting every building code and fire code imaginable. And you end up in, one ends up in some level of consternation about this. So I just bring this to your attention. It's one of these ongoing issues, and this came up in sort of the regulatory relief, discussion. And so I know that I'm not alone, but that was just one solicitation in a room full of hospital leaders, and they brought this to my attention. And I know that this is now to your attention and at CMS and so forth. But my larger point is, what should we be thinking? Because this subcommittee represents the entire spectrum of Congress. We represent it geographically, in terms of experience, philosophically, the whole thing. You've got a wide range here. What do you want us to be thinking about, and particularly the next 5 and 10 years? What's the discussion going to be about Medicare in the next 5 or 10 years? Stipulating that we understand the demography that Mr. Kind mentioned, the aging of baby boomers and so forth, but a little bit more blue sky. What are your last thoughts on what you want this subcommittee to be thinking about? Mr. Kazoukas? Did I put you in a Polish community a minute ago, by the way? I think I did. I think
Greek.
I called you Kaczynski. What should we be thinking about?
Thank you. And thank you as well for raising the question about the hospital that you mentioned. It's really indicative, I think, of the kinds of things that we're trying to address. And Kate, for example, has really been quite focused in many of her daily energies on a new initiative the administrator has launched that we're calling Patients Over Paperwork. And the focus of it is to address precisely the kinds of situations. I can't speak to that particular requirement, let's say, or situation, of course, but the kinds of requirements that are really distracting our healthcare providers from focusing their energies on solutions that this committee and the Congress and the administration are committed to in terms of helping deliver solutions for patients. We're also working hard, and Kate is a good part of this as well, on sort of a corollary effort to make sure that the measures that we use in Macra and otherwise are meaningful ones, a meaningful measures initiative. And so very excited about the opportunity to raise it. I know that you offered that as sort of a critique in some level of the current system, but I also wanted to assure you that a big part of our work in this administration is to address those very kinds of situations and to address the sort of the underlying concerns, both with respect to the range of CMS requirements, but also particularly with respect to Macra. And I think that leads me to the sort of the blue sky question and answer a bit. And I'll say that there's a sort of two parts, I think, to this. And ultimately, one part is the communication. I think Mr. Reed challenged me a bit to think about that in new ways. And this is where you all have been such good partners at times, because you do, as much as I am talking about patients and communities, I'm here in Washington now every day and working intensely with a team on driving this change. You all do hear from your communities so directly, and the kinds of input you give us about the way we talk about these things, the way we think about these things. That's a huge asset to us to be able to engage in that dialogue with you. I don't think there's a perfect answer. There's got to be obviously a sort of a way to talk about this in each place, but I think continuing to practice frankly, how we talk about these things in good part to people so that they make sense, so that they aren't abstract sort of policy notions, but really present themselves as something that can make an impact in people's lives. I think the second part comes back, and this is sort of more about what we're trying to achieve here, is really recognizing that as hard as it is to put patients in a position in the driver's seat, as difficult as that may be in some circumstances, that at the end of the day, it's really the only solution, because the patient, the doctors, as much empathy and care and resource that they might bring to a patient, at the end of the day, the patient is the one who's experiencing sickness, and the patient is the one making choices about their care, whether, however, whatever circumstance they're in. And so that is so important, and I feel in some ways that I'm telling you that value-based care means this, means that the patients are in the driver's seat, and to me it's in part common sense because of that sort of fundamental fact. And I think that if we don't lose sight of that point, that ultimately the patients are making these choices about how they access care, and that we can support them by ensuring that they're in a position to access the care that they choose that's right for them, to do so in consultation with their physicians who bring so much empathy and concern and expertise to their situations, and that we recognize the important role that families and communities play in supporting each individual patient. That if we do that, we will ensure that value-based health care isn't something that is created in Washington, but an opportunity for each patient to decide for themselves and to assemble for themselves health care.
That's very good. Well, thank you both for your testimony today. It was insightful, and we've benefited from it, and I appreciate it. We look forward to this continuing discussion. Dr. Goodrich, that patients over paperwork sounds very interesting, and I'd welcome the opportunity to for us to hear more about that, you know, in kind of a briefing setting. So
we'd be very glad to do that. We love to talk about patients'
okay.
paperwork.
Yeah, terrific. We're a welcome audience for that. As a reminder for the record, any member wishing to submit a question for the record will have 14 days to do so, and any members can submit questions after this hearing, and I would ask that the witnesses respond in a timely manner. The committee stands adjourned.